All right, good morning, everybody, and welcome to our Help to Hold Community Resource Webinar Series. My name is Jenna Sistad, and I'm with the Ocean Monmouth Health Alliance. Every month, we host this series to recognize not only the great work of our coalition partners, but to raise awareness about the Community Health Awareness Months. So this month is March, and it happens to be Colorectal Awareness Month. And so we have Giovanna here from the CEED team, Cancer Education and Early Detection, to take us through a presentation about colorectal health. So thank you, Giovanna, and thank you to everybody else who's here today. We're going to go ahead and get started. We'll pass it over to you, Jay. Thank you.
Thank you, Jenna. Good morning, everyone. As Jenna said, my name is Giovanna Zakatelko. I'm the bilingual patient navigator for NJ-CEED, and I'll be talking about colorectal cancer and some of our NJ-CEED services. So March is National Colorectal Cancer Awareness Month. Here, I just wanted to share a picture with you all of the Monmouth County Commissioners proclaiming March as Colorectal Cancer Awareness. Pictured here are Bonnie Woodward, which she works for one of our partners, Red Bank Gastro, and Michelle Batista. She's holding the proclamation. She is a survivor and a huge advocate for CRC awareness and screening. So let's start first by going through the anatomy of the colon just to get a little bit of background information on it. So colorectal cancer starts in the colon or rectum. These cancers can also be called colon cancer or rectum cancer, depending on where they start, but they are often grouped together because they have many features in common. The colon and the rectum make up the large intestine, which is part of the digestive system. Most of the large intestine is made up of the colon, which is a muscular tube about 5 feet long. The parts of the colon are named by which way the food is traveling through them. So the first section, as you can see in the picture, is called the ascending colon. It starts with a pouch called the cecum, where undigested food comes in from the small intestine. It then moves upward on the right side of the body. The second section is called the transverse colon. It goes across the body from right to left. The third section is called the descending colon because it travels down on the left side. And the fourth section is the sigmoid colon due to its S shape. And the sigmoid colon joins the rectum, which connects to the anus. And just also the colon works to absorb the remaining nutrients of our food after it goes through the small intestine. So polyps in the colon or rectum. Most colorectal cancers start as a growth in the inner lining of the colon or rectum. Polyps are quite common, especially as you get older, and most polyps are benign or non-cancerous. Some types of polyps can change over time, but it depends on what kind it is. For example, hyperplastic polyps are small benign growths found near the rectum and are considered low risk since they rarely turn into cancer. Inflammatory polyps are also known as pseudopolyps, which are created by the body's reaction to chronic inflammation in the bowel. Then we also have this word is kind of hard, adenomatous polyps or adenomas, which are common and are likely to turn into cancer if they're not removed, as well as these other two, the sessile serrated polyps and traditional serrated adenomas. They are also high risk as they can develop into cancer if not treated. Other factors that can make a polyp more likely to contain or develop into cancer are size, number of polyps, and histology. So for example, if a polyp is larger than 1 centimeter, if there are more than 3 polyps found during a colonoscopy, or if there is any dysplasia, which just means an abnormality or change in the cells that are seen in the polyps. So if a cancer forms in a polyp, it can grow into the wall of the colon or rectum over time. As we can see in the image, the wall of the colon and rectum is made up of many layers. CRC starts in the innermost layer and can grow outward through some or all of the layers. And when cancer cells are in the wall, they can also grow into the nearby blood vessels and lymph nodes. From there, they can travel to other nearby lymph nodes or to distant parts of the body. The stage or extent of spread depends on how deeply it grows into the wall and if it has spread outside of the colon or rectum over time. The earliest stage of CRC is stage 0, and then it ranges from stages 1 to 4. But the lower the number, the less the cancer has spread. The staging system used more often for CRC is the American Joint Committee on Cancer, which is called the TNM system, which is based on 3 key pieces of information. T stands for the size of the tumor, N, the number of lymphodes that are affected, and M, the site, if distant sites are affected or metastasis. Now we're moving into colorectal cancer risk factors. Many of them are lifestyle-related risk factors, and some of them we cannot change. But however, most or more than half of the risk factors that are linked to CRC, we can change. For example, maintaining a healthy weight, type 2 diabetes, smoking, alcohol consumption in certain diets, such as those containing meats, a lot of red meats, processed meats, or meats that are cooked at high temperatures, such as when you grill them, broil them, or fry them. Also, having a low blood level of vitamin D and not eating enough fruits and vegetables contributes to CRC. Some of the risk factors that we cannot change include age, race and ethnicity, sex at birth, having a cholecystectomy, which is having your gallbladder removed, and family history of CRC, as well as inherited syndromes. So people age 50 and older are more likely to get CRC, but in recent years, the incidence rate of people aged 20 to 49 has increased and is projected to keep increasing every year. Also, American Indian and Alaska Native people have the highest rates of colorectal cancer in the United States, followed by African American people. So some colorectal cancer signs and symptoms include change in bowel habits, a feeling that you need to have a bowel movement that's not relieved by having one, rectal bleeding, stool that is dark brown or black, cramping or abdominal pain, weakness and fatigue, and unintended weight loss. So colorectal cancers can often bleed into the digestive tract. So sometimes the blood that is seen in the stool makes our stool darker. However, most often it does look normal. So it might not be a red flag to us most of the time. Over time, however, the loss of all that blood builds up and it can lead to anemia. So sometimes the first sign of colorectal cancer is a blood test showing a low red blood cell count. And also some people even have symptoms of the cancer that has already spread. So for example, if the cancer has spread to the liver, your doctor might feel an enlarged liver during the abdominal exam, or you may exhibit signs of jaundice, like yellowing of the skin or whites of the eyes, or you may have trouble breathing if the cancer has spread to the lungs. Prevention is key. So get screened. Colorectal cancer is one of the most preventable cancers worldwide. People at average risk of CRC should begin screening at age 45. And average risk just means that you don't have any family history, personal history, or polyps. So some of the tests that are used to screen are stool-based tests, such as a FIT test or fecal immunochemical test. This test is done, and all of these other tests are done in the comfort of your home. This one is every year. There's also a guaiac-based fecal occult blood test, which is done every year. There is a big difference with this test because it does not differentiate whether the blood detected comes from your colon or your stomach. And then the mtsDNA or multi-targeted stool DNA test, which is known as Cologuard. That one is every 3 years. There are also visual or invasive exams such as colonoscopy, which is considered the golden standard for screening. And this is done every 10 years if you're normal risk. You can also get a virtual colonoscopy, which is a CT scan, a type of CT scan, or a sigmoidoscopy, which is only going to look in your rectum and the sigmoid colon. So it doesn't really go all into the colon, the transverse or ascending or descending. So that's why a colonoscopy is the golden standard. A blood test is, like said previously, often the first sign or the first test that leads us to think that you may have colon cancer. So the New Jersey Cancer Education and Early Detection NJC program offers free to low cost screenings for breast, cervical, colorectal, and prostate cancers for uninsured and underinsured Monmouth and Ocean County residents ages 21 to 64. We have case managers and patient navigators that will help facilitate appointments, transportation, diagnostic workup, and referrals into treatment. We are affiliated with FQHCs, hospital networks, imaging centers, and specialty providers across Monmouth and Ocean counties. And JCEED is available throughout all of New Jersey, and assistance is provided regardless of citizenship status. We provide screening services for all genders. These include clinical breast exams, mammograms, pap tests, pelvic exams, HPV tests, and the FIT or FOBT test. And if you do get a positive result for the FIT or FOBT test, we will cover that diagnostic colonoscopy. Prostate exams are also covered, or PSAs, and then diagnostic testing if results are abnormal, as said previously. If you are diagnosed through CEED, we connect you with our clinical case manager who will guide you in to applying for the special Medicaid that we have for eligible patients who receive a breast or cervical cancer diagnosis, referrals into treatment using hospital-based financial assistance or charity care for those who do not qualify for the Medicaid. And all of this will help lessen the financial burden during treatment for the individual. We also provide transportation with Uber Health. We will be able to assist individuals with an Uber ride to and from their scheduled medical appointments. And with colonoscopy, it's always tricky because the patient is getting anesthesia, but we have worked out a workflow with our providers where we can still provide an Uber as long as they are accompanied by an adult at all times. So if you have any questions, I'm more than happy to answer.
Thank you, G. I'll let everybody else go first. I do have a couple of questions that I was jotting down as you were speaking. Does anybody have any questions? You can feel free to take yourself off mute or write it into the chat. Okay, I'm going to ask then the question that I have. You talked a lot about like changes in cells and polyps. So I'm wondering the difference, if you might know it, between fissures and polyps. Like the fissures being the tears that we see. And if there's any like relationship between the polyps that form and the fissures that have occurred, I guess.
So I believe that fissures are most, I guess, like ulcers than the polyps, because polyps are specifically the abnormal cell growth that turns into cancer, whereas fissures are tears that could be caused by something else, like medication or our diets, or sometimes I know too, irritable bowel disease.
Okay. And I guess maybe my more focused question is like, do fissures end up leading to polyps at all?
That I'm not quite sure. I wouldn't be 100% sure on that if fissures do lead to polyps. I mean, yeah, fissures do lead to polyps.
Okay. I can follow up with one of the providers at the health center to see if we could get that answer.
Yeah, and I could definitely ask Bonnie at Red Bank Gastro to see if she could provide some more insight on that.
Okay, cool. So that's the one question that I have. And then I was wondering if you can talk just a little bit more about the partnerships that you have with the different centers. I know you kind of touched upon it a little bit, but can you talk about the process and how that kind of works if we have a family that comes to us in need of a screening, whether it's a CRC screening or any other screening, and how like CEED works so directly with our partners to make it very easy for a family to get linked with a service.
Sure. So if you have a family or individual that is interested, they will connect with myself or Sharice, and we'll do a quick intake interview with them to make sure they qualify. So based on their age, that they are a New Jersey resident, and we also take into consideration their income. And then from there, it's fairly easy. We just connect them to one of our FQHCs. For example, if you're in the Freehold area, Freehold Family Health Center, we also partner with Ocean Health Initiatives, Ocean County Health Department, and we usually have direct access to the schedules, or if not, to someone at that facility that will help us make the appointment for the individual. And we stay connected with them throughout the whole process to make sure that they did go to the appointment, to make sure that they don't need transportation, or that they are not encountering any other barriers that prevent them to get the care they need, as well as to make sure they don't need any diagnostic workup.
Excellent. That's wonderful. So that warm handoff to the site and then even follow up after. That's great.
Yeah,
All right, thank you.
thank
Does
you.
anybody else have any other questions for Giovanna? Okay. All right. Well, thank you, Giovanna. I'm going to give a couple of quick updates on our next presentation on our Health to Hold series. It's going to be next month on April 23rd at 10 a.m. Again, virtually, just like this. We're going to have the American Cancer Society team joining us to talk with us about their Voices of Black Women study that they're promoting. This is a long-term study. You do not have to have a cancer diagnosis. It's more on the preventative side of things. So we're very excited for that presentation. We will be recognizing National Minority Cancer Awareness Month, and Michelle Dea will be our speaker. The other thing to note is that we have another Spanish CPR class coming up. That will be on Tuesday, April 29th, starting at 10 a.m. It will be held at the Crossroads building in Freehold. So if anybody is interested in that, they can get in touch with Karen Ubeda. I can put her contact information into the chat box. She does speak Spanish, so she can help folks easily register. And we will be hosting, again, our female inspired event that will be in person at Casa Freehold on Thursday, May 8th. We are finalizing the flyer now, and we'll be sending out opportunities for folks to exhibit. We're going to kind of try to do the same way that we did it last time, where we have the CEED team right next to the Central State team that is able to, schedule those appointments for people on site. And it was very successful to do it that way last year. So we'll continue with that cycle. We'll be offering food opportunities. The HIV mobile will be there. There'll be, we're going to have some sponsorships coming in, hopefully to have a DJ again. So it'll be a fun event. And again, that's going to be on May 8th from 10 to 1 at Casa Freehold. So more information to come on some of that. But if there are no other questions, I just want to thank you all again for being here, and give another thanks to G for being a wonderful presenter, and give you back, you've got a half an hour of your day here. Thank you, everybody, and talk to you all soon.